in high HIV burden settings in Africa. And I think that what has been quite good in all the time that I've been part of the HIV prevention trial network is that there's been a lot of focus on, of course, on Africa, and as the continent with the highest burden of HIV, it's always great that the HIV prevention trial network and other networks funded by the US government and others, including the European Union, have actually chosen to focus on a major a major health or public health issue. But I think, the epidemic has evolved over time. And I think also what has happened is that there's a little bit more appetite now to do research in arenas or on populations that there was no appetite to do that before. But I do think that there are still research gaps, and those research gaps represent very challenging ethical legal issues that need to be addressed. And so I thought I would focus on some of them. And in particular, I thought I would actually just focus on, two populations. And I'm going to keep this relatively short and just, some of the key issues that I wanted to highlight here. But I'm going to be focusing on injection drug users in Africa, which is a very neglected key population. And I'm also going to be focusing not just on the MSM populations in Africa, but specifically on the transgender populations in Africa. Both those population groups are relatively under-researched, and there's not too much of focus on them. But I thought I would just start off by giving you guys some stats, both at a global level and then also coming down to the African level and highlighting that, what the issues are. So, of course, this is something for those of you who are involved in HIV research, you would know that people who inject drugs are a highly stigmatized population. And generally, globally, populations who inject drugs have poor access to health and prevention services in publicly funded HIV and injection drug use prevention services. This is something that's not specific to Africa. It's actually common throughout the world. And, there have been a few attempts at getting global stats on the prevalence of injection drug use and the proportions of people who inject drugs. And, what has been found is that people who inject drugs are, of course, affected by various related but separate injection-related, health harms. And this includes, of course, HIV, but of course, a whole bunch of other infections, including, HPV infections, but also overdose and soft and skin tissue infections. And, attempts, because we'll never know, this is probably an underrepresentation, but, for countries that do report their stats, there's been evidence now that at least in 190 countries, of which 102 report injection drug use prevalence, this is probably an underestimate because some countries are embarrassed to admit that they have problems. So we never really know whether this is actually accurate or not, but it does give us some starting point. And, essentially what these types of studies and, findings have highlighted is that there's an estimated, even if this is a conservative estimate, but about almost 15 million people aged between 15 and 64 who inject drugs globally. So this is quite a big population of, neglected people in a sense who don't really have too many services, but also have major research gaps. And I think what is particularly concerning for HIV in particular, we've just focusing on HIV, is that there's multi-person use of drug injection equipment. And of course, as we all know, this is a major risk factor for bloodborne infections. And this, of course, includes HIV and hepatitis B, hepatitis C, and of course, there's the soft tissue and skin tissue infections that come with that. So this is, of course, well known already. And just to move on to, the other issue, which is maybe looking at this from the African perspective. And I think it's important to start off by saying that there's very, very limited data from Africa, which highlights, of course, a gap, an evidence gap. So there's a paucity of statistics from African setting. And, as I said, this highlights in itself that there needs to be much more research from African countries. Now, where research has been done in African settings, what some studies, very limited studies, they may not be quite well sampled, may not be representative, but essentially, what we have found from studies that have come from African settings, they found that a scarcity of drugs can actually facilitate the transitions from non-injection drug use to injection drug use. And so, there's the shortage of needles and syringes precipitate syringe sharing. Now, this is, of course, possibly happening in other countries as well. But of course, in Africa, you've got extreme poverty. And a few studies that have been done, and this may be something interesting for people who are not too familiar with this, but what some studies have found is that where there's extreme poverty, the needle use is a little bit different. And it can lead people who inject drugs to deliberately inject the blood of someone else who has recently injected. And this has particular names in sub-Saharan Africa. It's known as flash blood or Bluetoothing. And of course, there are similar practices in other parts of the world, like South Asia. In Pakistan, it's known as jerking. It's known as booting or khun buzi in Afghanistan. So this is, something that happens in extremely poor settings where there's extreme poverty. So, this is not a typical type of thing that may happen in many affluent settings, and especially in settings where there are public health programs to try to reduce shared needles. But of course, in extreme poverty settings, this is what has been found. And, we're not really certain whether this is more wide. And part of that reason is because, again, there's a paucity of data from African settings. So what I just want to highlight are what are some of the very limited findings that have come from Africa. And usually, if there's any sort of studies being done on injection drug use, South Africa is quite a liberal country in terms of its stance on many different issues, including MSM populations, which we'll come back to soon. But of course, also it's quite a permissive research environment to do this type of research. And of course, in a country like South Africa, you need to do this type of research. As some of you may know, it's the world's most HIV burdened setting. Almost 20% of the world's population of HIV is actually in South Africa alone. So this is quite a heavy burden of the world's HIV pandemic. And so, when you do studies in South Africa, so one South African study found that 26% of females and 13% of males reported to always share injecting drug equipment. And this is quite a high percentage. And 49% of all participants had used contaminated injection equipment the last time that they injected. And only 6% of participants had used bleach to clean their injecting equipment. This is quite an alarming statistic from the world's most HIV burdened country. And half of participants reported using a condom the last time they had sex. And of course, that means that at least half didn't use a condom. So, these are, of course, not just risks from HIV from drug use, but also from sexually transmitted infections as well. And when studies were done, and in this particular study, when blood samples were taken, a quarter of the participants had reported symptoms of a sexually transmitted infection in the previous 12 months, and 22% had worked as a sex worker, and of which 51% were females, but it also highlights 49% of sex workers were actually male. And the HIV prevalence amongst this group of participants was 14%, which is quite high. 80% amongst females, which is quite common. We find that in sub-Saharan settings, typically females are a high percentage of the population with HIV compared to males, but even amongst males, it was 13% of the population. So these are quite high prevalence levels in just one study in South Africa. And, I think what the study highlights, first of all, highlights some public health interventions that are needed, but it also highlights, the evidence gaps. But from a public health perspective, what it highlighted is that there's an increased need for access to sterile injecting equipment and more education around safe injecting practices, and of course, access to sexual and reproductive healthcare services for people who inject drugs in South Africa. And of course, what it also highlighted is that we need to have very specific and niche programs for people who inject drugs, but that address the specific needs of female participants or female users, people who use or who sell sex, and of course, particularly people from previously disadvantaged communities. And I'm sure many of you know that South Africa is related to apartheid. In fact, this year, we're having our 30th anniversary of the end of apartheid, and it passed actually a few days ago. So, it takes decades and decades to basically transform a country that has had hundreds of years of colonization and then a formal system of, colonization and slavery, then of course apartheid. So 30 years is a relative drop in the ocean. But, what has happened, thankfully, is that the government has been quite open now about increasing its funding on HIV interventions. Pre-exposure prophylaxis has been introduced. But of course, South Africa is just one setting. But it does give us a little bit of an idea of what kind of challenges the rest of Africa is facing. So, in terms of the evidence gaps and where research really needs to be done, is that there's, of course, very critical need to strengthen genomic surveillance capacity in African settings for specifically to pick up injection drug use, but of course for all types of modalities of HIV infection. And of course, given that injection drug use contributes to several overlapping epidemics, as what we found is that, when we're looking at injection drug use, because of the nature of injection drug use, very close contact, of course, there's higher potential for infections, for example, like COVID. But of course, you've also got HPV, etc. So there's, of course, overlapping epidemics when you're looking at injection drug use. And collective action, of course, is needed to improve surveillance and support for many, many low and middle income countries. And so, I think that this is something that is needed to protect susceptible populations and, of course, to protect and safeguard global health. But the problem is that, there's to highlight the need that there's a need for surveillance, you need, of course, some sort of data. And in many African countries, one of the issues is that there's almost a denial that there's an injection drug use program, or that there's no, sometimes no political appetite to even go down that direction. And many of you would know that, unfortunately, one of the legacies of colonialism is that while the colonial countries that have actually introduced some of these laws that we find in African countries today and many other countries that have been colonized, it's actually while those countries have abandoned those laws or are moving to more liberal policies, African countries actually double down and are quite conservative in enforcing colonial era laws. So, of course, it's quite difficult to get authorities in many African countries to even speak about the fact that there's an injection drug use problem and that these are people who, in fact, merit help and that your surveillance system, in fact, needs to cater for them. So, this is some of the challenges, and I'll come back to that because it's a common challenge with, of course, other places. And so in terms of the ethical legal issues with regard to injection drug use in African settings, like in many other parts of the world, injection drug use is criminalized in African settings. And of course, I think what compounds it in Africa is that, detention facilities are particularly bad. And there's sometimes major issues in terms of people being processed properly through the system. So you find people, once they get jailed, they sometimes languish in jail for much longer than you'd find in a typical Western setting. And of course, in terms of the ethical legal issues here, with authorities in African countries permit injection drug use in their settings, it's particularly tricky. And of course, this is sometimes the issue with sex worker population. Sex work is also criminalized in African settings. But I think, because sex work is more well known and is tacitly accepted in many African settings, sometimes there's more permissive attitudes towards sex workers than they are, in fact, towards injection drug users. And I think even if studies were permitted, we have to ask ourselves realistically, will the standard of care ever change? So if you show that you can introduce safe needle programs, will there be appetite amongst policymakers to do that? And I think, these types of open questions, which maybe apply in other settings as well, highlight the critical need for stakeholder and community engagement. And I think engaging with injection drug use communities, of course, holds challenges in itself and on its own. And this is probably common with many other settings, because how do you do, engagement of a community that may not, in fact, have the capacity to understand what you're doing for part of the time anyway? And would that actually be meaningful community engagement? What kind of strategies do you employ? And what kind of language do you use? And how do you get authorities to, in fact, not either raid the engagement session meetings or not, of course, try to prosecute people who participate in the study? And I think these are issues that may, in fact, be common with other settings, but they are particularly challenging in African settings as well. But I do want to now maybe just shift the attention a little bit, especially because of time factors, and look at the evidence gaps and the need for research in transgender and MSM populations in Africa. So as we all know, transgender people are an important key population for HIV research globally. And of course, many studies globally have found that HIV prevalence rates in transgender populations are actually significantly higher than populations like men who have sex with men. And I think, one of the important changes, which I was quite glad to see even within the HIV prevention network, is that, for a long time, transgender populations were actually included and subsumed within MSM populations and were kind of like grouped together as one population, but they've got quite distinct, you know, needs, and they've got quite distinct, I think, challenges that are specific to each group. So what has been quite good is that there's been a slow movement in some countries in the US, and of course the HIV Prevention Trial Network has been transgender studies now. I'm involved in one in Latin America, US. And so, studies focusing specifically on transgender populations are now beginning to happen, whereas before it was an MSM population that included transgender. But I think, when we look at where the evidence gaps are, this has not yet begun to happen in Africa. So there's a complete lack of transgender populations in Africa. I won't say a complete lack, but there's definitely a major evidence gap in so many respects. And at present, there's almost no data available on HIV prevalence and risk amongst transgender population people on the continent, especially outside of South Africa. In South Africa, there have been a few important studies, small and may not necessarily be representative, but I think it is something that at least we can say that there are some stats that are beginning to emerge. So as I highlighted a little bit earlier, I'm just going to use South Africa as an example. So South Africa is home to the world's biggest HIV epidemic. Over 7.7 million people have HIV in South Africa. It's almost 20% of the global burden of HIV. So for a country with less than 1% of the world's population to have 20% of the burden, you can see that this is, of course, a huge overrepresentation and a very heavily burdened country. But studies on trans populations in South Africa are quite possible. I think we became the fourth country in the world to legalize same-sex marriages. So you actually would find, and it's not uncommon to find transgender people in the general community. They're still very stigmatized, but these are some of the stats here. Transgender people are much more likely to have HIV. And of course, I highlighted this earlier, but one recent global review indicated that trans women are 66 times more likely to have HIV, and trans men are 7 times more likely to have HIV. Now, of course, what this one study showed is that HIV prevalence among South Africans who identified as transgender between the ages of 15 to 49 was estimated to be 19%. But, but amongst 15 to 49 in the general population was as high as 19%. But amongst trans women in Johannesburg, it is as high as 63%. And, what we don't really know is what is the prevalence amongst trans men in South Africa. So, these are quite alarming statistics. These are quite alarming even for people who are familiar with high burden settings. But, what is positive is that at least 0.3% of South African population comprise trans or gender non-conforming individuals. And we're finding out these things because, these types of studies are becoming more possible to do now. And I think it's because for a long time, research wasn't explicitly being focused on transgender populations. And I think I wouldn't be surprised if the stats are a little bit higher and, these may be underrepresentation of populations and stats in South Africa because these are quite limited. But I think it highlights that there's definitely a need to do more research and to find out what the prevalence levels are or what the incidence rates are. But also, it highlights there's an important need to conduct HIV prevention research on these populations. The need is very high. We don't really know whether, for example, the use of certain hormone drugs or hormone blocking drugs could affect HIV drugs. We don't really know if this would affect populations in sub-Saharan Africa or African populations. These are important issues that we really need to know. And what we have shown, and these are studies that have highlighted this, is that tailored trans services integrating sexual health and gender affirming services results in improved outcomes in both HIV prevention and in care. And what we do now need is that we do need now research to show this in African settings. And so, what we do know is that where studies have been done and where services have been rolled out, is that the provision of gender affirming has been impacted by societal stigma and discrimination at multiple levels. And this has had major impacts on transgender populations. And of course, we've got in South Africa and of course elsewhere, it's the same. There's very limited budgets for hormone therapy. And many of the centers in South Africa that focus on transgender populations, actually funded by the US government. By, and they are reliant on the South African government, though, for the supply of hormone therapy. So you'll find that, while some of the centers are sponsored for HIV prevention or for PrEP, but the hormone therapy, they're still dependent on the South African government. And what is, I can tell you almost certain, is that hormone therapy outside of South Africa is virtually unknown, and it's definitely not being provided. So, what would be important, though, is to show what the percentage of people are that actually need these types of therapies, what the percentage of populations would be in need of, of, or showing that, for example, services that integrate sexual and gender affirming services are needed, but we have virtually none of those types of research to highlight the need here. So in terms of the ethical legal issues, I messed up the O there, but in terms of the ethical legal issues here, I think, one of the important moves now is looking at, even within the HIV prevention trial network, is looking at multi-purpose prevention technologies. This is the new buzzword in HIV. It's where you can prevent HIV and, for example, have one type of intervention that is HIV and contraception or HIV and STI. So I think, when we're looking at multi when we're looking at multi-prevention technologies, it's very, very important that we don't have a gradual approach at looking at only women, then looking at men, but also making sure that when we're starting these types of research on promising technologies like multi-purpose prevention technologies, when we want to, and if we want to maximize the impact and public health utility of these technologies, we need to do research on these emerging technologies on high burden populations right from the outset. And we're talking about neglected key populations. And this includes, of course, MSM and transgender populations and injection drug users. And I think historically, what has happened is that when these new technologies like PrEP, but also now we're looking at multi-purpose technologies, when they're being rolled out, very often funders, including major HIV research networks that I support, they tend to roll it out first in women, then sometimes they'll roll it out in men, then you move to MSM, and then lastly you come to the populations that really need it. And I think from an ethics perspective, it's quite important that we start including these types of neglected cohorts right from the very outset, and that they don't become recipients or study participants of these new technologies much further downstream, because then the evidence base lacks and there's no impetus and there's no need for public health authorities to include them because there's a lack of evidence to show that it would work. So, as we explore new prevention technologies going forward, it'll be quite critical to do social behavioral research. And of course, when we're doing multi-purpose technologies, social behavioral research has to accompany biomedical research to enhance our understanding of both the preferences and the needs of target populations like injection drug users in Africa and transgender populations in Africa. And this, of course, will ensure that the products meet diverse user end needs and preferences upon commercialization. I think, what we have learned is that when we have new prevention technologies like PrEP or even injection HIV drugs, it takes quite a while for those to get registered. So there's quite a lag between the studies coming out, findings being published, and then, of course, regulators, then approving it, and then policymakers then adopting it. And then, of course, once it starts getting rolled out, because you've got stigmatized populations or relatively neglected populations not being included at the outset, it takes even longer for those populations to get included. And so, of course, what sometimes happens in the private sector is that these populations are provided with these drugs off-label, but the problem is that, most often, as I'm sure you'd know, in the US, sometimes off-label is not covered by health insurers. And of course, typically, MSM populations or transgender populations or injection drug use populations are such marginalized populations, they can't afford private healthcare insurance. So it takes quite a while for the state sector to get the evidence, prove that it would be feasible to implement and to roll out in those populations. So I think, the sooner we get these populations into our HIV prevention research or multi-purpose technology research, where we're looking at STIs or we're looking at contraception or any of these different types of multi-purpose needs or diseases or infections or conditions, we really need to include these populations at a very, very early stage. And I think in light of evolving norms, just more thoughts from my side, I think in light of evolving social and cultural norms, we also need to consider how to evolve our notions of self-identity. And I think, these are notions that have evolved over a long period of time. Historically, the HIV prevention community have described certain cohorts as MSM, men who have sex with men, or transgender. But of course, now, non-binary, pansexual, etc. And I think, the HIV research field or the science field need to evolve with these different terminologies to make their research more inclusive. So I think, when we're looking at future research, we have to focus on high priority cohorts that have traditionally been studied in silos, for example, MSM cohorts, injection drug users, or even transgender. And I think going forward, the research agenda should consider focusing on stimulant using MSM or transgender populations. I don't see why we shouldn't actually look at not combining, but why we shouldn't be looking at first studying only transgender, then you study injection drug users. I think this is something where you find these two types of drug use and risk profiles intersect. And I think what I would like to see going forward is the research agenda considering the use of or the testing of interventions on injection drug users who may, of course, be transgender as well, or substance users. And I think that these types of studies should be conducted in settings where the populations have been historically marginalized or understudied. And of course, I'm here, focusing on Africa, Latin America, even South Asia, settings where you find these are historically neglected populations. There's relatively high burden of HIV. And I think that rather than having a very filtered approach where it's done first in North America, then of course in other settings, I think we need to go to settings where the burden is very high. So as I pointed out, and I've said it a few times, in a setting that has burden of HIV, there should definitely be an appetite for looking at research, but not just the traditional research of looking at one population group and then moving to the other and then moving to the other, almost in a step down way from least controversial to most controversial. I do think that we need to look at high risk populations, but also those who are historically neglected right from the word go. So I think, I've made these points again, but I think that focusing on high-risk populations are going to carry very high ethical legal risks. And I think this will require a lot of thinking on the part of the ethics community, but also the communities that are the scientists who are conducting this. And so I think, researching MSM populations or transgender persons or substance users is going to be particularly challenging in many African countries where there's not due process of the law, and of course where this is criminalized and where there's a lack of even a human rights framework that can even maybe offer some protection. So I think that type of research, while I'm advocating for it, will require very nuanced consideration and intensive stakeholder engagement. And I've been involved in research settings for the HIV prevention trial network, maybe Bob Klitzman has been as well. But what we have done is, as part of the HPTN, we actually go to some of the study settings and engage with policymakers. I remember we did a study that is looking at the feasibility of rolling out HIV PrEP in African populations, but in specifically, it was quite a forward-thinking study called HPTN 075. It is looking at the feasibility of rolling out PrEP in MSM populations. And the setting where the study was done was actually where MSM populations were and behaviors were criminalized. So what we ended up doing was going to those settings, meeting with the police, meeting with prosecuting services, meeting with community leaders, traditional leaders, political leaders, and engaging with them to ensure that when the studies were done there, that people would not face arrest or study sites would not be raided for names. And, we engage with religious leaders. So I think, it's going to take that kind of engagement process to start rolling out these types of studies in these very challenging settings. And, I'll highlight one example where, where most of the world is moving, most of the world, some countries accepted, but where most of the world is moving towards a more progressive way of actually interacting with high-risk populations. We've had for a long time in Africa, African countries implementing or not abolishing colonial era laws. I've noted that before. But of course, relatively recently, we had in Uganda a new law, a new anti-homosexuality act that is not a colonial era law, but that was passed by parliament and signed in. And, as part of the HIV prevention trial network, we were engaged by investigators who are quite concerned about the implications of this. So, these are the types of challenges you have in Africa where new laws, of course, are being passed as in this type of day and age that are actually contrary to where the rest of the world is going. And of course, I don't have to say this, but of course, in the US, we have a similar type of challenge. You've got the Dobbs decision, which is quite contrary to what else is happening in the rest of the world. And of course, you've got quite conservative, decisions being made by even your state courts and by your state legislatures, where relatively conservative laws are being passed. And of course, this is happening in other parts of the world as well. So, research and HIV research is becoming more challenging. It, for a while, was looking quite positive that research was going to be easy to do or easier to do. But I think, in particular, conducting this type of research in African settings is particularly problematic when you have, for example, the death penalty being applied. So, I'll leave you with these types of issues, but this is why I'm saying that the last point here, when we're looking at nuanced consideration and intensive stakeholder engagement, it's quite critical to do this type of engagement when your research participants could face the death penalty, which is not common in other parts of the world. So I'll end there, and I'll be very happy to take questions. And sorry for starting late. We had a bit of tech issues for me to join the room, but I'm happy to now be here, and I'll be happy to take questions. So apologies for talking fast, but I am conscious, of course, of the time issues as well.
Well, Jerome, thank you very much. It was fascinating, and the floor is now open. So feel free to either raise your hand if you want,